Hi, everybody. I wanted to introduce you to my special guest today, Dr. James Greenblatt. He is a pioneer in the field of functional and integrative medicine and is board certified in both child and adult psychiatry. He currently serves as the chief medical officer at Walden Behavioral Care in Walden, Massachusetts, and is an assistant clinical professor of psychiatry at Tufts and also Dartmouth College Giesel School of Medicine. He is the author of 7 books, and we're going to be talking about his most recent one, which was just released, called Answers to Anorexia. If you want to get a hold of Dr. Greenblatt, I will be putting his contact information in the show notes. So stay tuned. So I want to welcome my special guest to the show, Dr. James Greenblatt, who I told you about his bio in the intro. And we're going to be talking about his new book, Answers to Anorexia. So welcome.
Thank you, Carolyn. It's good to be with you and see you again.
Yeah, you too. So, anorexia has been around for a long, long time. And I've been treating anorexia for decades, and I know you have too. And for the most part, the treatment hasn't changed in numerous decades. So what has inspired you to write the book and to talk about a different way of treating anorexia?
Well, I think, you're exactly right. Nothing has changed. And the desperate attempt by families and patients and doctors are just increasing. Certainly, we know rates are increasing. I think what has changed for me is that the rest of the medical community for the last 5 years, one, has acknowledged anorexia as a brain-based illness, and two, acknowledged that we don't know how to treat anorexia. There was a brilliant editorial in this last month's Journal of the American Journal of Psychiatry by Dr. Bulick, an eating disorder expert, and she just kind of hit the medical community between the eyes, saying just what you said, nothing has changed. We have to do better.
Yeah, because the mortality rate for anorexia is higher than most other psychiatric conditions. And yet it seems so odd that in the medical community, the nutritional basis of anorexia has been almost completely ignored. And those of us who've tried to introduce that have often been marginalized or called alternative, et cetera. So what do you think is the problem in our, whether it be our training or whatever, that keeps people who are seeking to treat anorexia from looking at something so obvious that, people are starving, so therefore there must be some problem with nutrition, right?
It's a little frightening because it is quite obvious. We're sitting across from malnourished, starving individuals, and to think of nutritional supplements is just not part of the protocol. I think it's a couple reasons. One is, as you know, there's no training in nutrition for doctors. Right. So doctors aren't kind of leading that fight. And there's no other kind of treatments, there's no medicines. So people, our medical colleagues, feel helpless. And I think the biggest reason is a term that I picked up years ago called the tomato effect. It was written by pharmacists, pharmacologists in the 80s, just describing the cultural mode of treatment and how nutritional therapies, it's not part of our culture. Just like eating tomatoes, we thought were poison for 200 years in the United States, so we never ate tomatoes. And nutritional solutions is just too simple for our medical kind of model. It's not in medication, and I think it just can't be embraced sometimes. Because
do you think that's driven in part by the fact that the pharmaceutical industry has such a large lobby with physicians, and that if it's not something that we can write on a prescription, that's seen as just not scientific enough?
I think both our patients and our colleagues are pretty kind of, stuck and if not rigid around a medication solution. I mean, it's on TV every day.
So, can you explain to the listeners a little bit about why medication? Because I know in many of the treatment centers where I've been called to consult or ones where I've worked in, oftentimes psychiatrists will put patients with anorexia on 2, 3, 4, 5 medications at a time, at the same time. Can you explain a little bit about why that usually is not going to work?
Sure. I mean, I think it's just another example of desperation and trying to help these kids or these adults. So one medicine doesn't work, we keep adding more. Mm-hmm. The antidepressants I'm most worried about because they do not help anorexia nervosa, and it's usually the first line. And part of the reasons many of these medicines don't help, it's likely that it's just due to the chronic malnutrition. These medicines, adjust some of the neurotransmitters in the brain. And if we don't have the raw materials to synthesize these neurotransmitters, there's really no adjusting that can take place or make a difference.
So just for example, I don't think most physicians remember their biochemistry, that it takes, certain cofactors to make those neurotransmitters such as serotonin, dopamine, et cetera, in the brain. And without those nutritional cofactors, the brain can't make those feel-good chemicals.
Right. I mean, they're vitamins, minerals, and the precursor molecule is protein, the tryptophan or phenylalanine. So if our patients are restricting or starving, they're not getting, as you said, any of the factors needed to make these neurotransmitters.
I also saw that you say in your book that just restoring weight doesn't mean that good nutrition has been restored.
Yeah, that's been one of the most upsetting parts for me being in the field, because we get excited about, weight restoration and parents are happy and treaters are happy. But, calories will help, restore weight, but without the supplements and without the nutritional repletion, the symptoms are still there, the distorted thinking, the digestive problems, the sleep problems. So that's why relapse rates are so common.
And these symptoms that you're mentioning, that, for example, the distorted thinking, are all really symptoms of the nutritional deficits. Is that correct?
Yeah, I certainly believe so, because as we feed patients and give them supplements, their thinking's improved.
Yeah, absolutely. So do you make the same analogy about patients at the other end of the weight spectrum who many people think may be overnourished, but who may themselves also be malnourished, even though they're living in larger bodies?
I think it's similar, different nutrients, different deficiencies, but absolutely, over calorie, malnutrition in our patients with binge eating or obesity, it's not uncommon that we detect multiple nutritional deficiencies.
Yeah. So tell me a little bit about the analogy you make about looking through the wrong end of the telescope. What's that about?
Well, similar to the what you used earlier, what's right in front of us. So, when we are patients that are malnourished, starving to death, we focus on either therapy or other techniques that have not shown to be helpful. So I use the analogy of, rather than a telescope bringing distant objects closer, we turn it around and our starved and malnourished patients look very, very far away. And it's not what we address.
Yeah, absolutely. So there are dietary factors that go into the development of anorexia, and a lot of our patients with anorexia often present as being vegetarian or vegan or being on some kind of restrictive diet. What are your thoughts about those kinds of diets in treating people with anorexia?
Yeah, my thoughts are quite clear. When I started about 20 years ago, I run these parent groups, and one parent talked about their child going on a vegan diet, and then every other parent would share the same story. So it's been in my head for 20 years, but and I think there's a correlation. And now, what is the good news is the research clearly has supported it. A vegetarian or vegan diet, in particular, causes higher relapse rate, lower remission rates, and just poorer outcomes across the board.
So even when patients say, "Oh, I've been a vegan since I was 9 years old," you will encourage them to expand their diet. Or I'm a vegan because I don't want to kill animals. I'm an animal activist.
Yeah, no, it's complicated, and that's why we, as a field, we need to really address it and understand it. And I think that the two issues that need to get addressed are the nutritional deficiencies. And so a vegan diet is usually deficient in B12 or zinc.
Right.
So we're not going to make somebody eat animal products. Certainly encourage that during puberty and until they get better. But if not, at least acknowledging that there might be nutritional deficiencies associated with a vegan diet, like protein, zinc, and B12.
Awesome. So there's, the adverse childhood experiences study has been out for almost 2 decades now, I believe, and was started here in San Diego, where I have practiced off and on for some time. How do you incorporate all of the interesting and almost revolutionary information that has come out about the link between childhood adversity and then later risk for substance use disorders and even eating disorders?
Yeah, I mean, I think the longer I practice, the more I kind of get embedded in genetics and strong understanding of the family history and as a risk factor, and then being able to really dissect all the other risk factors, and be it trauma or adverse reactions in childhood clearly plays a role on that genetic vulnerability. And the complicated fact on treating eating disorders is many of those environmental factors play just as important role. So we need to understand both the genetic vulnerability and all these environmental stressors that affect our kids.
Yeah. And it seems as if there's more and more revelations coming out about wide swaths of the population of young adults and young people who have been victimized in some way, whether it be the gymnastics federation or at university health centers and so on. So it seems to me that that's kind of the setup for the next generation of people with these disorders, because these things are happening in our society on a regular basis.
Yeah, a couple of new studies, came out looking at just the diagnosis of PTSD or PTSD symptoms, and in an adult residential eating disorder program across the nation, and it was 60%, and for kids it was 50%, meeting criteria for post-traumatic stress disorder.
Wow. Yeah, that's really significant then.
Absolutely.
Yeah. So how do you explain the increase in suicide risk in patients with anorexia? Because you said in your book that 20 to 30% of anorexic deaths in anorexic patients are from suicide. Is that a nutritional component as well? Because I know that we've been studying omega-3 fatty acids and suicide risk, and even the military has been looking into that. Does that come into play in the nutritional component?
Well, I mean, that's the way, I explain it. I mean, I think the rates are, again, the highest suicide rates of any psychiatric illness, including bipolar or substance abuse, and the malnutrition. And I think the omega-3 theory, these girls and boys have been restricting fat for many, many years. Mm-hmm. And so I think that low levels of omega-3 has strikingly been associated with suicide attempts and risk. And the other nutritional deficiencies, I think, to me, has been the most convincing correlation.
Yeah. I have, just to go back to the trauma link, I wanted to ask you, because I know I've seen patients with anorexia who have had pretty severe trauma. And every time, you start to do work on the trauma, their anorexia, their behaviors, their restricting behaviors and other behaviors around food kind of get worse. So do the supplements help with making that, bridging that gap there?
Well, I mean, in my experience, helping support, brain function with optimal nutrition really supports psychotherapy, and particularly some of the psychotherapy that might be directed towards the trauma. Both substance abuse and trauma in particular, it's just seesaws. One gets better, the eating sort of gets worse, and vice versa. And I think with some biological interventions, nutritional therapy, maybe medicines, that we can kind of balance that and help patients move forward.
Do you have a case that you could share from your book that illustrates some of these principles we've been talking about, or even a newer case of someone you've seen?
Sure. There are just so many kids and young adults that we have seen that have just gone through multiple treatment programs. Yeah. And it's just not one or two. They go to different states and different programs. And so, one case said, I spoke to the family recently that they're doing well. This is, 22-year-old girl, been in and out of treatment since age teenager, 15 or 16, does well in a treatment program, restores some weight, goes home, and then relapses. And one of the powerful interventions around nutritional support is, I believe, that it can prevent the relapse because it's just beyond the calories. So, this young lady ended up going to one of a residential treatment program, did well, and then started losing weight again. And the family contacted me, and without a hospitalization, and just by the patient's motivation, wanted to get back to college, started taking supplements. And these were, amino acid powders, zinc, fatty acid powders, and just helping them kind of focus on kind of nutrient dense food. And the most important message I share with parents and the patient in particular, we're not trying to help you gain weight. We're just trying to restore nutrition so your brain is better, your digestion's better, and anxiety improves. And that usually supports. And for this girl, she was able to get back to college without getting back into a program.
Just one last question, and that has to do with anxiety now that you mention it, because many of our patients with anorexia have predisposition to anxiety. And in your book, you talk a lot about what an integral role that plays in anorexia. Can you say a little bit more about that?
Sure. I think it's anxiety is one of the few things our patients are looking for relief for. They want help because the anxiety, I think, drives so much of their behaviors, because restricting, not eating, actually decreases the anxiety. And a lot of the anxiety is these intrusive thoughts about their weight, about their body image. And then when it gets bad, it's what's going to happen if I eat. Somebody will get hurt, or I'll not be able to function. So whatever we can do to decrease the anxiety is kind of the first step in treating the patients with anorexia.
Yeah. Well, I love your new book. I think it's a wonderful guide for clinicians and even for parents who are looking for answers for their kids, because it really gives a completely different approach, but with research and scientific basis on how to treat this hard to treat disorder. Anorexia, I find, is much harder to treat than any of the eating disorders. And I think it gives hope to people that they can actually recover. And it makes sense too. Beyond that, it makes sense. It's logical. So appreciate having you on the podcast, and look forward to seeing you on one of your next webinars. Thanks.
Great. Thanks, Carolyn. Take care.